Thanks, Case. We stand today on the unceded lands of the Lenni Lenape people and acknowledge their care of these lands over time.
We read this land acknowledgement, which is offered by the Nanticoke Lenni Lenape Tribal Nation for those who seek to honor the Lenape people and their territory preceding an event in Lenapehoking, also known as New Jersey. The land upon which we gather is part of the traditional territory of the Lenni Lenape called Lenapehoking. The Lenape people lived in harmony with one another upon this territory for thousands of years. During the colonial era and early federal period, many were removed west and north, but some also remain among the continuing historical tribal communities of the region. The Nanticoke Lenni Lenape Tribal Nation, the Ramapough Lenape Nation, the Powhatan Lenape Nation, the Nanticoke of Millsboro, Delaware, and the Lenape of Chesterfield, Delaware. We acknowledge the Lenni Lenape as the original people of this land and their continuing relationship with their territory. In our acknowledgement of the continued presence of the Lenape people in their homeland, we affirm the aspiration of the great Lenape chief Tamanin that there be harmony between the indigenous people of this land and the descendants of the immigrants to this land, as long as the rivers and creeks flow and the sun, moon, and stars shine. This labor acknowledgement is offered by Dr. T.J. Stewart, Assistant Professor of Higher Education and Student Affairs at Iowa State University. We must acknowledge that much of what we know of this country today, including its culture, economic growth, and development throughout history and across time, has been made possible by the labor of enslaved Africans and their descendants who suffered the horror of the transatlantic trafficking of their people, chattel slavery, and Jim Crow. We are indebted to their labor and their sacrifice, and we must acknowledge the tremors of that violence throughout the generations and the resulting impact that can still be felt and witnessed today.
Maria, we can't hear you. You're unmute. You're muted. Sorry.
I'm so sorry. I apologize. I'll start over. For us at Gathering Ground, we read these statements to make visible what has been invisible to so many, particularly people racialized as white. We acknowledge these historical truths of the theft of people and land, enslavement, forced migration, and forced labor. And though this is our history, this cannot and must not be our future. We at Gathering Ground are committed to working in community and constant dialogue with all of you in disrupting this fatalistic view and creating new norms and new structures for a more equitable world. Before I turn it over to our special guest, I want to tell you a little bit about Gathering Ground, especially for those of you that are joining us for the first time. We are a multiracial, multicultural, multi-generational, and socioeconomically diverse movement of people committed to taking action that creates thriving and equitable communities. Gathering Ground offers a variety of programs designed to address systemic issues and empower individuals to become agents of positive change. From our community engagement initiatives to collaborative learning experience, each program, like today's briefing, is developed and crafted to cultivate a culture of equity and justice. I want to recognize very quickly the people who made this, who worked really hard on this briefing. Our presenter, our wonderful presenter, Cecile Edwards, the Executive Director of the New Jersey Birth Equity Funders Alliance, and her dedicated team at NJBEFA. Karen Kambambi, hope I said that right, Karen, Assistant Project Manager, and Journey James, Program Assistant. The team at Gathering Ground, Casey O'Brien, our Director of Programming, and Anaya Brown, our Communications Associate. This work is made possible with the support of the Geraldine R. Dodge Foundation. I want to thank all of you for being here with us today and making this a priority in your busy schedules. Even if it's only for a few minutes, Shakira, we appreciate you making us a part of your day, especially today, as some of us celebrate Halloween. We hope this is one of many Gathering Ground programs that you participate in, and we look forward to engaging with you in the future. Okay, in true Gathering Ground style, today's program will be a conversation. The Gathering Ground team will help facilitate. So if you have a question, please use the raise hand function, or you can put the question in the chat. We'll do our best to answer every question. And I just want to remind folks, we are about to engage in a discussion of a very sensitive topic. So please feel free to do whatever you need to make yourselves comfortable and take care of yourself. Okay, I'll turn it over to Casey. We'll do a brief introduction of our guest speaker, and then we'll get started.
Casey O'Brien, as Maria mentioned, I'm the director of programming. I am a 40-something racialized as white woman with short hair, glasses, and giant Princess Leia headphones on right now. I'm delighted to be able to introduce you, for those of you who don't already know Cecile Edwards, to your speaker for today. So Cecile Edwards has a passion for maternal and child health, family wellness, and believes that it is a cornerstone to a well society. Cecile is a postpartum doula, maternal equity consultant, and maternal mental health and wellness advocate, New Jersey paid family leave leader, perinatal postpartum family coach, assisting individuals, families, organizations in facilitating conversations and creating systems that improve maternal wellness via her business, Mommy Evolve. Cecile is a 16+ year educator and a member of Advocates for Children of New Jersey's Parent Leadership Council. Cecile was a proud member of the New Jersey Birth Equity Funders Alliance community, specifically the advisory committee, and is happy to continue that work side by side as the new executive director of the New Jersey Birth Equity Funders Alliance. Cecile looks forward to working with the philanthropic organizations and community organizations to build capacity for community work. She loves to hike and travel. She lives in Somerset, New Jersey with her 14-year-old daughter. You can always learn more about Cecile and about the work of the New Jersey Birth Equity Funders Alliance at their website. I'll drop that into the chat momentarily. But without further ado, I'd like to turn it over to Cecile. And I'm going to get your slide deck up, Cecile, and we'll get going.
Thank you so much, Casey and Maria and Anaya, for, first of all, inviting me here to have this conversation with everyone. And I'm excited about what is going to ensue. I see a lot of friends in the room, people who I'm familiar with, who I've worked with, and new folks as well. And I look forward to getting to know you also. I do want to acknowledge that I now have a 16-year-old. A 14-year-old. Yes, I have been in this work for a few years now and have learned so much about philanthropy, about birth equity that I didn't know. I also want to acknowledge that I come to this work with many identities as well, not just as a postpartum doula and a mother, but a child of immigrants, as someone who has not just had a child, but had a pregnancy that did not come to full term. I am also a sister, right? Sibling. I have 8 siblings, 2 nieces and a nephew. I come from a very large family, and all of these color my views. It colors the way that I see life, and it is part of what brought me to this work. I will also acknowledge that I do believe that this is an issue not just for those who can give birth, but for everyone, because everyone is born, right? We all come through that process. I always make the joke that if you have not come through that process, I would love to have a conversation with you, but from what I know, everyone does. And so I just want to acknowledge that we all have this as a common issue that we can take on, be aware of, and advocate for in many ways. And that will be infused throughout this conversation, ways in which what we can do as individuals in our families, in our homes, to improve and bring awareness to this issue as well. So to get started, we're just going to start with the conversation on what is birth equity, right? When you hear the term birth equity, what do you think of? And then we're going to talk about some health statistics, some maternal health data, both the US and New Jersey. And then I'm going to talk a little bit about New Jersey Birth Equity Funders Alliance's work and how we see our theory of change and how we see our ability to help move the needle in a positive direction. And then, of course, facilitate discussion. After each section, though, if you have questions, I'll address the questions. But I do recognize that everyone in this room, again, has their own level of expertise. So if there's anything that you want to share, respond to, etc., feel free to do so. I don't own anything. And, I think that everyone has their expertise in their own right. So with that, if you can put in the chat what your definition of birth equity is, what you think it is, what you have come to grow to understand it is. You may have started out with a particular definition and then it grew into something else. I know for me it has, for sure. So what is your definition of birth equity? And if it's even more comfortable for you, you want to come off the microphone to just share really quickly, or to open your microphone to share really quickly, you can certainly do that.
Rather writing really in-depth answers in the chat, but don't be shy, folk.
Thought-provoking, I know.
Indeed, indeed. Okay, we've got a couple in here. Cecile, Naya or Maria, does one of you want to read
Yeah.
that, or does the person want to come off mic and say?
Okay. I'll go
No,
ahead and
I just wanted to add access to quality care and autonomy in the care that you actually receive. That is probably broad, but in a nutshell, quickly, that's what immediately comes to mind for me.
Absolutely. And ensuring that everyone has that quality of care, a good quality of care, irrespective of, insurance type, irrespective of color of your skin, and irrespective of your culture or language, etc.
Yeah, we've got a comment from Shakira. Every pregnant person has an equitable, read, safe, and generous opportunity to give birth to a healthy child.
I see Shakira wrote the ability to create expanded support and care for all individuals to have a safe and healthy birth, regardless of race, creed, sexual orientation, financial status, or disability, etc. Everyone, regardless of circumstances or race or background, has what they need so that they can have a healthy birth outcome. Yes. And Gary says equal access beyond any barriers of race, social, economic difference, as well as respecting individual choice in birthing, from free birth to traditional hospital birth. This is very important, for sure. Yes.
So we've got Joanna and Lisa. Joanna says, what birth equity means to me, everyone having access to quality care, regardless of your skin color, sexual orientation, financial status, religion, culture, and age. And Lisa, my definition is that Black and brown women are fully supported medically and psychosocially so that they are no longer unseen or suffer poor outcomes for themselves, newborns, from preconception through early years, to eliminate disparities and differential outcomes compared to race.
Absolutely. Love that. So I'm glad that all of us have, well, those who shared and perhaps those who didn't share as well, have, an idea of what birth equity is and have thought about it. Perhaps this definition has shifted. I know for me, the definition shifted when I really put into perspective and understanding that it's not even just about birth, but it's about women's health overall throughout their lifespan. That shifted a lot for me in having those kinds of conversations with, researchers and doctors who have that perspective as well, and individuals, and even just filtering that through my own life and thinking about birth outcomes in that way. Next two slides. So slide The next slide. Dr. Joya Creer Perry, founder and president of the National Birth Equity Collaborative, defines birth equity as the assurance of the conditions of optimal births for all people with a willingness to address racial and social inequalities in a sustained effort. So again, this is the definition that when people convene, you'll often see this definition that was created by Dr. Perry. And it encompasses what many of you have said. Next slide, please. So again, just to get into the US maternal health disparities, if you can go back one slide. I wanted to level set with that. Compared to other high and middle income countries, the US has some of the worst maternal health outcomes in the world, particularly for Black women. Black women are 3 times more likely to die from a pregnancy-related cause than a white woman. And Black women are more likely to experience complications throughout the course of their pregnancies than white women. And one of the things that we often hear cited talked about is weathering. And weathering is this concept that the persistent racial barriers that Black women face is what contributes to overall poor health outcomes throughout a Black woman's life. Black women have a heightened risk of pregnancy-related death, irrespective of their incomes and education levels. So many studies have shown that this doesn't have anything to do, and not just heightened risk of related death, irrespective of their incomes, but when compared to, for example, a high-income Black woman to a poor white woman in this country, the white woman has better outcomes than she does. And we've seen many cases in the news of, for example, Olympians and track stars, et cetera, who have experienced poor birth outcomes and poor treatment in their birthing process, even though they're well known and have the funds to go probably to the best places that you could go to. So we acknowledge this. We see this as a part of the maternal mortality crisis in this country. And I also want to acknowledge, in having discussion about maternal mortality and birth equity, that we have not just mortality, but morbidity. So there are a lot of cases in which Black women in particular they may not die, but they have morbid issues related to pregnancy or that cause a near miss, et cetera, in their pregnancy. And that is actually, and yes, Black infant mortality as well. And that is actually significantly higher than the mortality rate. The morbidity rate is significantly higher than the mortality rate. So that's something to consider, that, we are not just talking about when someone dies, but we're talking about their life, quality of life, right, to experience a good pregnancy. Okay. The other part of this conversation is that implicit bias contributes to disparities in maternal health, including how obstetricians and gynecologists counsel Black women regarding treatment options. And recently in the state of New Jersey, there was nationally there was a report, but recently in the state of New Jersey, there was a report that came out that showed that Black women are, I believe, 25-30% more likely to have C-sections unnecessarily. And unfortunately in my work, and I've heard of many being forced to have C-sections in hospitals. And obviously this kind of treatment is unacceptable, right? In such a vulnerable time, no one should have to think about or be threatened with violence or anything else to receive something that they don't even need, quite frankly. And there's a lot of layers to why that happens. But the point here is that it happens more prevalently to Black women. Yes, to fill ORs, it's something that, they get paid more for. And also it just comes back to, again, respecting the birthing process, the natural birthing process, and people's autonomy and decision and their ability to choose as well. Okay. So in New Jersey, the statistics show us that New Jersey ranked 47th in the United States for its high maternal infant mortality rate. And though we are now 27th in the country, the stats for Black women have not changed. So it has improved for everyone else, but Black women. A Black infant in New Jersey is more than 3 times more likely than a white infant to die before their first birthday. And Black women die from pregnancy-related causes at 7.6 times the rate of white women. So some of us have heard these statistics often. Some of us have never heard them. They're very jarring. They're disappointing, to say the least. And I want to add that with this, Black women in New Jersey are more likely to have preterm births, to receive early prenatal care, and as stated, receiving unplanned C-sections. Okay. So with that, I feel like we all can take a collective deep breath and do what we need to do to take care of ourselves, because even though I've heard these things a lot, it's disappointing. Disappointing to say the least. And yes, we're only 29th only because other states did worse, all right? And so that is an important point to, when we're talking about stats and data, that's a whole nother conversation that I feel like that's a whole webinar to have. It's important to understand how to even interpret data well. So yes, when we say that New Jersey is now 27th, it's only because other states did worse. And, you know, even when you have, even if there's 10 deaths, if that's 10 deaths too many, right? Next slide, please.
I think we have a question from Lisa.
The one how to raise
Oh, I'm
my
sorry,
hand.
it is.
It's okay.
I always forget. I wanted to ask about the backup. I certainly appreciate, you know, if this is egregious, and the fact that you stated that the data, the result, or the outcomes for Black women have not moved since the worst of it. I didn't realize that was that was true with the improvements, but I wanted to understand the facts behind some of these comments about the C-section. What data is there as to what's driving it? I can appreciate, you know, we can't have doctors who are unethical or worse, but to fill ORs and higher compensation rate, it's obviously much more of a risk, so you get paid more to do this procedure. It's not an easy procedure. What data is there to back these points up? Profit margins and so on. There's now a report card by month, I think, that all hospitals have for births and complications, and their records are affected, their scores for safety, and these measures, which must change, their not, I don't know about their payments, but their record and other rewards or other aspects of how of their ratings are affected by these very metrics, because there is a statewide focus to right these problems and eliminate these problems. So what can you share with us, Cecile?
Yes. So there was I think, Joni, you have the article that was shared recently. But yes, in the Maternal Data Center, the New Jersey Maternal Data Center has the stats for hospitals, individual hospitals, and what some C-section rates are. There's also a national database. If you go to, what is the name of the website? Anyway, Joni, you have it there. If you can share it in the,
Yeah, I've been looking at that data
yeah.
to see how all the hospitals in the region we fund to see what's happening, and it's very important data,
Yes.
but I don't know what is beneath it in the inside the
Well,
tent.
what is beneath it is profit margins and bias. I mean, that this is what,
Bias I get, but
so birth
just for
is
a
not
to say that,
profitable.
for higher compensation rate or to fill ORs, that's, those are big statements to
Yeah.
find data for that.
Yeah. So, I mean, C-sections are, it's a surgery, right? And
Yeah.
surgery bill at
Makes
higher
sense.
amounts. Natural birth doesn't bill at a very high amount, right? So, and I don't purport to be a expert in this, but because they bill at higher amounts, and the bias comes in because oftentimes, unfortunately, there is not a trust in the natural physiological birthing process. And so there's a push to move things forward. And oftentimes that is what is given, the option that is given. Other options are not given. Surgery is given as one of the higher options. And anyone who's been in the birthing room who has an understanding can certainly share their experiences, because I think that that is important. I'm a postpartum doula, so I usually take care of women after they've had C-sections. But yeah, that is it. But there will be some information shared after, and such, to be able to give you that information. But there are national databases as well as the New Jersey database. Yeah. Tonique, you can go ahead.
Right. I'm over here jumping, and I was trying to type, and I was like, you know what? It might be better if I just say it.
Sure.
But there are certain types of coercion that happens in the labor and delivery process, in the labor and delivery room. And so one of my things is a lot of the times, because I'm a postpartum doula with the partnership, and a lot of times when I walk in and I talk to a mom, and she's had a C-section, and she's endured any part of labor or an induction process, a lot of the times it ends up um, the cocktail of Pitocin
Pitocin, yeah.
starting before the
Yeah,
epidural,
yeah.
and then when they get the epidural, they already worn out, and the exhaustion of
Yeah.
experiencing more than 24 hours of labor, the staff is now starting to talk, well, maybe you might better go do a C-section. The baby is probably too big, or this, that, or the other thing.
Mhm.
And a lot of times I really would like to see that mobile ultrasound come in and try to figure out really what's going on, but they never use that. So it's a coercion, a cocktail with the Pitocin saying the baby's heart rate going up and down, the baby is in
Right.
trouble. So there's different coercion mechanisms or ethics that,
Or risk assessment,
right.
because I mean, I've heard this. I am not diminishing what is really happening, but I have heard this from some peers about doctors, white people whose children were, this was ultimately the plan, that they go in for induction and they start the Pitocin and blah, blah, blah. Like, this is the plan to avoid or, make this easier plan for a doctor. And I was like horrified.
Yeah.
So there's a lot of unpacking to do.
Right.
That and
Yeah.
a lot of miseducation about
Yeah.
what your rights are as a
And
patient.
empowerment, and yes.
Right.
Mhm. So yes, okay, thank you, that's helpful.
Thank you so much, Tonique. Thank you so much, Christina, who
You're
shares that
welcome.
fear is a big one. And if you
And
want to
yes,
come off and
the
talk about
cardiovascular and all that is a big, those are huge.
Yes.
issue.
Coercion through fear. I think the conversation of really discussing how often, and you want to be a good mom, don't you? We want a happy, healthy baby, not really thinking of the mental health impact
Mhm.
on our clients as well as as a full spectrum doula. Thank you.
Thank you. All right, back to you, Cecile.
Thank you. So to continue the conversation, the primary causes of Black maternal mortality in New Jersey, the leading causes of maternal deaths is cardiovascular concerns embolism, hypertension, and of course, incongruent and racialized care, right? And we know, going back to the conversation about C-sections, unnecessary C-sections put women at a much higher risk for long-term medical complications. So there's this, connection in all of this to women's health and autonomy and wellness that is critical to understand. And I did see someone note that there is, when we're talking about funding and we're talking about data and we're talking about focusing on the issues, we want to make sure that we're focusing on what the significant concern is. So yes, Tashira, cardiovascular complications associated with pregnancy continue to surge, but they did not get the same view or the same focus to help ease the issue, but instead that attention was diverted to other things such as mental health challenges, SUD, for white women. So when we talk about, SUD concerns and things like that, yes, they're a significant concern. But when you're talking about Black maternal mortality, that is not the primary issue for Black women. The other thing that I would put here too is, yes, mental health challenges. I think that is often honestly not researched or dealt with enough for a lot of other reasons, right? I've heard too many people say that they, when it came to going to the doctor and filling out forms, they didn't tell the truth in those forms because they knew that telling the truth about their mental health, et cetera, would cause some kind of CPS involvement, et cetera, et cetera. So there's a lot of very nuanced things that happen that data cannot capture. This is why I love that we have so many doulas here that have been in the rooms and understand those nuances. They make a huge difference in the way that we see these issues, understand these issues, and address these issues. So next page, please. So with that, the end of that particular section, if anyone has any questions or comments, please feel free before I jump into another segment. Thank you, Joni, for putting the maternal mortality report there. We also have our YouTube channel. We did a data learning series that really dives deeply into the data around maternal mortality and morbidity nationally, as well as in the state of New Jersey. So Joni will share that as well, and it'll be shared at the end of the conversation. Okay. And Christina says that also most times they aren't explaining the questionnaire to people, the Edinburgh questionnaire that is given to postpartum moms to help them to see where they are mentally after giving birth. Any questions, comments about that section before we jump into the next section?
Not seeing anything in the chat.
All right, fantastic. So in the state of New Jersey, and nationally and in the state of New Jersey, I'm going to talk a little bit about both, but mostly about New Jersey. There's a lot of efforts to combat this issue. And starting with the First Lady and community-based organization led effort to create the Nurture New Jersey Plan, which is a strategic plan that has recommendations, many recommendations on how we can, and when I say we, many departments, counties, et cetera, of the state of New Jersey can tackle this concern in a concerted effort. That plan was created. And from that plan, the New Jersey Birth Equity Funders Alliance has been working to operationalize the need to support community-based organizations that focus on birth equity. And so the Alliance, the mission is to reduce maternal mortality in New Jersey and eliminate racial disparities in birth outcomes. And we do that through coalescing various funders that fund from preconception to age 3 to support families those who support families, community-based organizations that support families. Next slide, please. And we do that in several ways. We do that through amplifying the voices of birth equity leaders, because we know that, as we see in this room, many people have experiences, and those experiences are very valuable to how we can shape the policies, the procedures, the ways in which we do things throughout the state of New Jersey and nationally, quite frankly. We invest in community-based organizations. Many of our organizations have received grants for the very first time, or small organizations under $500,000 revenue, and are Black, Indigenous, and Latina led and or serving. So the other thing is the building of the infrastructure for cross-sector partnerships. So working with organizations like the Maternal Innovation Health Authority, working with community-based organizations, but also working with other philanthropies and organizations in the state of New Jersey that are interested in birth equity. Well, everything touches birth equity, so I can't even say interested directly in birth equity, because we certainly work with those that address social determinants of health, such as housing and food security, et cetera. Many of our grantees address that as well. And so just looking at the ways in which we can build those cross-sector partnerships. And then the fourth one, we don't worry about it too much. There is stuff to go in there about that, but bolstering our own internal financial and organizational capacity, which shifts the way that we even see who we fund in the ecosystem of funding and how we fund them, right? So we have organizations that we have funded that are LLCs. We funded also individuals, projects, et cetera, that came to New Jersey to amplify and to ease burdens on birth workers, as well as bring accountability to hospital systems. And so that is a bigger conversation, but the first three are the ones that we will certainly focus on today, and how we do that work and how we can think about doing the work of in any area really, but how we do that in birth equity, or we're trying to. So next slide, please. Sorry. So how do we amplify the voices of birth equity leaders? So we stand with them in promoting birth equity. We take their feedback and infuse it into the work that we do to ensure that those voices are being utilized, those solutions are being brought to the table, that they themselves are being brought to the table. One of the things, the very first things that NJBEFA did was to assemble a community advisory committee, of which I was also a member of the inaugural committee. And these excerpts, these birth equity advocates and experts that range in various skill sets, from doulas to midwives to OBGYNs, all advocates in some way, shape, or form, to the table to steward a fund that they create the priorities around to distribute to community-based organizations that are doing the work in birth equity. And so they do literally all, the work around setting the priorities. The very first RFP was around postpartum equity, because they recognized that even though a third of deaths were happening in the postpartum area at that time, there wasn't a lot of conversation around what was being done to assist in that process. And they rightly wanted that to be the focus of the first RFP, and created that. And we were able to give 9 grants, I believe, 9 grants in that first round. The other is mutual aid stewardship, which is very new. But our mutual aid stewards are very spirited and getting a lot of fantastic work done. And the idea here was looking at we did a study at the inauguration of this organization in 2021. And in that study, that landscaping study, we noted that a lot of people were calling for more wellness and care of our perinatal health workers. And so from that, the mutual aid stewardship was born and launched earlier this year. And we're hoping to be able to distribute our first set of mutual aid funds early next year. And similar to the Community Advisory Committee, they are, stewarding the funds, guiding the planning and the design, et cetera, et cetera. And one thing that I have to also note is that we do compensate our advisory committee and our mutual aid stewards. I think this is very critical when you're dealing with community and you're connecting with community, to ensure that you value their expertise, their time, and the work that they have done and are doing in their communities. It's critical, very critical. Listing policy changes or other efforts you are focused. So thank you for asking that question, Lisa. So we are developing a policy agenda with our advocates based on the education process that we went through this year. So we worked with a organization called River Crossing, and from that, from the education that they provided through that, we're building a policy agenda, which we will be launching or discussing in the coming year as well. So yes, so the policy advocacy training. Any questions about this? And this is just the way that we see doing the work, because there's always this conversation and this knowledge that, Black, Indigenous, Latinx organizations are underfunded, funded too short amount of time, et cetera, to be able to do their work and do it well. And this is a way to address community solutions, not address community solutions, but bring community solutions to rise to the top of any issue, quite frankly. I think that there is much work for us to do in philanthropy and giving around just how we do that work. And so NJBEFA is sort of taking some level of charge in operationalizing what that can look like and having conversations with people on what that can look like, in order to, for whatever issue it is, serve the issue of birth equity in particular. So. Lisa, are you raising your hand?
Yes,
ahead.
because
Okay.
I'm so lame. Why can't I find the hand raising thing?
I don't know.
I'm the oldest one here. Okay. I'm interested, given the work that we do with providers, and we are funding a number of projects to support birth equity.
Lisa, can you just share what organization you're from? By the way,
Oh,
we
yes,
know each
I'm
other,
sorry. I am Senior Program Officer at the Healthcare Foundation of New Jersey, and as a funder, a regional funder of healthcare, the grants are based in the greater Newark area, Essex County, and a little bit of Union and Morristown, Union County and Morristown, more of the underserved communities of color in Union County and in downtown Morristown. So that includes 6 hospitals and birthing hospitals, and we're working in addition with supporting a doula initiative through the VNA Central in Essex County, and Postpartum International, which is national and does run support groups virtually and in person, and is leading efforts to educate OBGYNs and other birth workers. They're just getting started to develop what they aim to make the most culturally competent and relevant curricula and training, and it's offered with CEUs in other ways as well, and then create referral networks to their support groups and be an asset in addition to what exists already. We're also funding Perinatal Health Equity Initiative. That work was really to collect data from primarily Black women of their birthing process and maternal health journey, and they're summarizing all that, and comorbidities was a very significant finding. So that's an example. There's more that could happen, and training perinatal health workers in mental health first aid geared to pregnant and through the continuum. So there's more opportunity, but I am particularly interested in what you've learned from the hospitals right now, where we could be helpful in moving them along. what you're experiencing there and any recommendations you have for education, for quality improvement, or anything else, for even for educating, women themselves.
Yeah, so I think that this is a huge area when it comes to birth equity, and particularly when you come to the intersection of community leadership. When you're talking about hospital policy, when you're talking about how doulas are seen and viewed in hospitals, I don't know that we can do much work without that having more conversation and correction. In terms of us working with hospitals, we have funded the Earth app. And the Earth app is a organization that collects data or stories from families and birth workers, and then shares that with hospitals for quality improvement of their processes. So that is what we have done in terms of funding and, trusting organizations, or that organization, trusting community-based organizations to do that work in community. So I would say, just in short, that this is the work of hospitals, right? To do that, to trust those who are working, who oftentimes have very high rates of success with the families that they work with, that are trusted by the families that they work with. That would be the work that the hospital needs to do. But that is my contention. So I don't know if anyone has another idea or way of putting it based on their experience of being in hospitals. But yes.
I feel like it's a lot more conversations, and some of the challenges is that I don't know if there's really any doula collectives that really can, there's powers in numbers. And I think even in I've worked for a federally qualified healthcare facility, and I understood that the program was a part of a HRSA grant and it had a term, but even the OBGYNs in the clinics that I actually worked in did not know who I was. And I was employed there for 2 years and continuously asked for like a lunch, a meet and greet, or something like that. Because if doulas don't have the relationships with a vast amount of OBGYNs, a lot of the times we go into that labor and delivery and then we have to introduce ourselves, even though a lot of times I tell my moms, make sure your OB knows that you have a doula, but it's still a challenge if it's an OB that I don't know. Now I have some that I know and they be glad to see me when I'm there, but the ones that don't know me, they really don't know me, and there's no bridge the gap to introduce doulas to these OBs and, develop that rapport.
Thank you, Tonique, for that.
Mhm.
Any other thoughts on that? Just jump
Well,
in.
I would say that good evening, everybody. It's Toshira. Our purpose in the space in the medical setting is to support that parent, to help them to be able to navigate for themselves. We're not there for the healthcare team and for their convenience or to be included, because we serve a specific purpose and the relationship is built long before they even get to the hospital space. And so it is important that doulas go to the doctors with their families, that they're included by the family into, whatever needs or desires they want for their birth and what they envision. Birth plans and all of that is nice, it's cute, but they're not legal documents. We get a lot of pushback. There are different types of doulas. There are different styles that doulas operate with, but ultimately the goal is for that person to go in the hospital with a full belly and leave with full arms. And all too often, birth outcomes are diminished by, a lot of things, social, structural, and I really think it is important that doulas work really hard in community and with the family prior to getting to the hospital to have the baby, you know. And with that, those first 42 days postpartum, where the morbidity is highest, this is where we're losing the moms. And so it's not even in the hospital. That is the hospital is the easy part. But getting them home and then getting them through those first 6 weeks, where culturally that's the lying in period. And then, you know, we have to help them to navigate. And especially if there are other children, there's a lot of moving parts. What if that parent is unhoused? What if there's an open DCP&P case? What if there's substance use challenges? Community doulas do a lot of work, and we are undercompensated, and we are under supported. But the work we do is deep because it is literally family revitalizing and life-saving on so many levels. And so it is important that the work that we're doing is properly documented so that we can show exactly what areas of concern that we're touching and that we're able to really tell the story and give the full narrative, because, you know, we're not there for the doctors. We're not, you know, it really, honestly, if I never see an OB, if I never see whoever's caring for that person, if I never see them, that's fine. Because as long as that parent knows that when they see them, that they know what to say, they know the 5 questions to ask. How is this going to affect me? How is it going to affect my baby? Is there an alternative? How does this affect my milk supply? And what are the risks over the benefits? As long as they know how to constantly and persistently and consistently ask those questions and be satisfied with the outcome, ultimately, I feel like it's really up to them, because these hospitals, a lot of them do not have, they say they have doula-friendly policies. They say that they welcome us, but they don't. We feel it, we see it, and it's challenging, especially when, again, there's not a lot of access. And so that diminishes equity as well, because of a person in, I would say, more affluent counties in New Jersey can pay $3,500 to $5,000 for a doula, whereas a person in Cumberland County or Atlantic County, where the disparities are great, can't afford that. You know, they can't even find one. So we have to look at how that really plays into the equity. You know, how is a person in Atlantic County getting the same as someone who lives in Teaneck, you know, or Hoboken? And it's just, again, it's a lot of moving parts. Thank you.
Yeah, sorry. I don't mean to interrupt. I just want to make sure that we're able to get through the rest of Cecile's presentation. And thank you all for the wisdom and the experience and the passion that you're sharing. You know, it's heavy stuff. So, Cecile, I'll turn it back to you.
Yes, thank you. And I, you know, I love and lean on the expertise of those who live this work every day, right? I support that. And thank you all for giving this robust, detailed understanding so that people can really hear and understand what goes into this, because I think that there is a level of, in this birth equity space, there's a level of repeating of history, if you will, when it comes to doulas and the work that they do. Sort of like what happened with, you know, granny midwives in the early 1900s, where the work was diminished, their work was co-opted into hospital systems and never acknowledged. And so I have to bring that to fore as well, that we don't want that to happen. We want in 30 years, you know, if I ever have grandchildren or great grandchildren, I don't want to have to think about whether or not my grandchildren or great grandchildren are going to have to deal with this. And this is where we have to converge with this conversation. And what can we do to ensure that? And so respecting our birth workers, our community birth workers, working with them, understanding the solutions that they're bringing to the fore is based on lived experience as well as working in communities, and is not profit driven oftentimes, right? Because if you're in community with someone, you want the community to be well. So I'm just looking at some of the comments here. Community doulas are taking on enough, right? So one of the conversations is that, and I just came back from a birth equity funders conference in which this was brought up a lot, that we are not and cannot just rely on doulas to do this work. And I think that that oftentimes is brought in the conversation, that, you know, we are looking to them to solve this problem, it seems, when they're not the ones that are creating this problem. So educating doctors, the doctors in hospitals without fair compensation is honestly unfair. It's unfair to put this pressure on them, exactly what was just said. So how do we come to some kind of understanding, compromise? Compromise may not be the word, actually, because we want the best for birthing families, which is every family, right? Systemic issues affect birth equity, absolutely. So though we cannot ignore social determinants of health, when it comes to this, there's not enough housing in the state of New Jersey. Healthcare is, just even getting into that conversation, the way that healthcare is structured. We just recently worked with the New Jersey Healthcare Quality Institute on
My bad.
sorry, Asha, a patient mapping journey that shows how families who are may not be underinsured, be you know, immigrant families, et cetera, what their journey is like, right? So that we can see that, because we hear it, but we don't see it in visual form to really understand. And I think that that is something that we can do oftentimes as funders to really bring issues to the forefront, to bring them to MCOs in these places, to let them understand what is really, really happening and how this is affecting everyone. And that will be a study that will be on our website at some point so that everyone can view that. Yeah. How are hospitals currently educating hospital staff at the moment on the systemic issues? Are they being educated? Or is there really an understanding of what is happening and how the staff are contributing to the issue? You know, they may feel like they're not, but I think that sometimes you have to bring that accountability to individuals and how they may be contributing to birth equity concerns by things that they may say, things that they may feel like they can skip over and not do, or things that they do, et cetera, et cetera. So yeah, there's a lot of comments here about that, and a lot of history and a lot of different things. Thank you, Joni, for adding the doula time use study, which is a study that was done by the Health Connect One. That shows they followed several doulas to show like just the nuance of all of the things they go through, talking to their clients via text, and how much time it actually takes, and what you would actually have to pay a doula if you were to pay them for the level of time and expertise that they utilize. So I think that it's a really great study to be aware of and to utilize. To look at, and perhaps even think about the way that you, as doulas, et cetera, organizations that work with doulas and other perinatal health workers, think about collecting data, or work with your individuals to collect data, to show the level of work that they are doing, and compare that to how the work that is being done in hospitals and the outcomes. Okay. So I think we collectively agreed that we're going to pause here and take questions. Is that the case? I just want to make sure, Casey, that I'm on the right.
I mean,
path.
if you are done with what you want to talk about, then yes, we can absolutely do that. I know you also were going to talk about some of the policies that were coming up, I think,
Yes,
but we can do
so
that in Q&A if you want.
really
You know,
quickly, next slide. Really
yes, absolutely. Yeah, I mean, we've got until 4, but we want to make sure that we leave, you know, we've been able to actually address a bunch of questions. So, you know, thank
The
you for
time
doing
went
that,
really
and we'll have
quickly.
more time.
Time went really quickly, so thank you for the time check. We can sit here and talk all day. Next slide, please.
Yes, absolutely.
I think maybe slide 15. So in New Jersey, you know, agree with it or not, Nurture New Jersey plan and you know, the efforts, 65 plus laws have been put into place in New Jersey to improve reproductive, maternal, and infant health. Home visiting program is one. That is actually an area in which our advocates are going to be doing some, having some education and advocacy in the coming year. There was also an establishment of the Maternal Infant Health Innovation Authority that will oversee the Nurture New Jersey plan and its continuance after the administration. Because, you know, again, I've been in rooms with actors in many other states, and quite frankly, in some places, they don't have the support of government. They don't have the support of funders, et cetera, because of the nature of the work in reproductive health, et cetera. And so, you know, I have to say that we can color ourselves lucky in some ways that we have had that for the past 7 years and we have certain laws. The meat, though, is the implementation, right? And how we really look at how things get implemented, and how we are able to really get the services to the families that are in need, right? Any questions about this? And we'll share the list of the different laws that have been enacted so far. But there's been many, from breastfeeding to family planning to, there's been many laws to doula reimbursement, et cetera, et cetera. And that's also another area that we'll be focusing our advocacy efforts in the coming year with our advocacy agenda. So, next slide, please. So one of the things that I always say, I love, you know, our focus on land acknowledgements and such. I also desire the focus on restoration. And I think that birth equity is one of these areas in which restorative justice practices and restoring traditions, which doulas, midwives, perinatal health workers bring to the fore, is the central part of not just acknowledging, but restoring the health of our communities. And so I always think to myself, for this presentation, I really wanted to consider what are some things that we can focus on, high level, mid-level, and on a very base level in our communities, that we can do to engage, to ensure that people are cared for in the ways that they deserve to be cared for. So these are just some of the things that I thought of. I would love to hear what are some of the things that you have done and would like to do to be able to see lasting changes and not just in a law being enacted. Because again, that's just, honestly, if on a scale of 1 to 10, I would say that that's up to 3, the work. The work from 4 to 10 is actually ensuring that this is embedded in the hearts and minds of people, and they really get why this is important, in their actions and their et cetera show for the real change to happen. So, you know, private citizens can support their communities by donating, by sharing the work, by taking care of those in community-based organizations that are doing this work in many ways, being a support system. Okay. Organizations and professional actions, you can enhance collaboration with community-based organizations. So when you're looking for a policy to change, when you're looking for a solution, think of who is embedded in that community. You know, when we know that a particular place is a food desert, are we going and looking at organizations that have already organized to do something about it? Are we going to them and saying, well, what is it that is needed so that we can enhance your work? Are we doing that? Or are we just thinking from the top and by looking down and considering what might be able to be done when you have someone already there doing the work? Political actions, of course, you know, engaging in your local politics, right? We often look at gubernatorial and national elections, but there's a lot of magic in the local politics. So supporting those candidates, knowing who they are, educating yourself on who they are, becoming them, right? That support and prioritize community health and equity. Next slide, please. And these are just some advocacy paths, you know, again, building community, contacting your local, state, and federal representatives as a group, right? So if one day you want to have a gathering together and you're like, you know what, let's all call this person at the same time and talk about this particular thing, right? They want to hear from you, believe it or not. Your local representatives want to hear from you. And trust me, they're hearing from people and they're hearing from the same people. They need to hear from you too. Support doula work. Pay for a doula for someone, right? I used to say to people all the time, you know that I'm a doula. I know a postpartum doula. I know birth doulas. If you want to support someone's birth, I promise you they don't need a million onesies, but they may need this this doula to come to their house and help them cook and clean and take care of them. Support independent midwives, attend appointments with a pregnant woman or family. Help a pregnant woman prepare for her visits and debrief afterwards. Stay informed and use the resources that are shared. So these are just some of the very basic ways that we can do advocacy at high, mid, and I don't want to say lower, but basic levels, everyday levels, I guess you could say. But I would love to hear what some of your thoughts are on how we can ground this issue and be advocates, what you have done, even the most basic thing. Okay. I'm then also going to look at that could be a convening opportunity in our region. You're attempting to quantify subjective perspectives and lenses when you invest funding in DEI and disparities in healthcare, that all data leads to bias and racism. We can't continue to use limited funding initiatives that are centered in the pedagogy of oppression have not led to quantitative change. You can't continue to do the same thing except expect a different result. I mean, this is absolutely correct. And the question is, how do we introduce different perspectives? How do we ensure that those different perspectives get infused into how we do things and shift, right? So I know that in NJBEFA, we look at the way that we do data. Oftentimes organizations, we look at data just to prove something. But the question for me is always, what is the community already proving through what they're doing, right? What are you showing us? We don't need to have another conversation. And then we can all then take that information and use it to create better outcomes. So Gary says, open up the discussion beyond the coalition the First Lady created and beyond Maternal Infant Health Authority to be more open to ideas and success happening. Absolutely. This is a multi-pronged thing. We have to bring everyone to the table. And, you know, one thing I must say that the First Lady did do was convene all of the stakeholders in government to have this conversation. Believe it or not, government organizations, they don't meet, like DOH, DC, they don't have conversations with one another, right? You would think that we do, but it's not something that happens, right? And I think that that was something that we can certainly use going forward. And I know, again, in our policy agenda for NJBEFA, that this is something that we are coordinating to have our advocates able to meet with DCF and meet with DOH and meet with MIA and all these different organizations on a regular basis to share their insights and share what is happening and ensure that there can be utilization of those efforts in improving overall in New Jersey, right? So I'll stop talking and let us bring the conversation to others.
Cecile, I think that's a perfect segue. We have about 15 minutes left in our session today. So if everyone agrees, I can go ahead and stop the recording. We can move into the formal Q&A portion of our call, and then we'll wrap up at 4 p.m. Does that sound good?
Sounds great. The last slide, though, I would like for us to leave on the
Sure.
last slide, just so people can know where they can go to connect with NJBEFA, slide 19. And also go to our YouTube channel to watch previous videos on various subjects that we have had learning sessions around.
Thank you so much for that, Cecile. I'll give it another couple of seconds just so that brings it. All right, I'm going to go ahead and stop our sharing right now, and then I will